Staff experiences of implementing seclusion and restraint reduction strategies in an acute mental health unit. There is a drive by the Ministry of Health to reduce the use of seclusion and restraint in New Zealand mental health services, as these practices are recognised as being traumatic rather than therapeutic for many service users and staff. The Ministry and TPO have recommended that mental health services implement the 6 core strategies for the reduction of seclusion and restraint. The 6 core strategies were developed by America's National Association of State Mental Health Program Directors and have been applied in the United States of America and other westernized countries to successfully reduce seclusion and restraint use. The fundamental principle underlining the 6 strategies is to prevent service users from experiencing further trauma through coercive practices. The strategies are: 1. Leadership towards organizational change. 2. Using data to inform practice. 3. Workforce development. 4. Use of seclusion and restraint reduction tools. 5. Consumer roles in inpatient settings. 6. Post-seclusion or restraint debriefing. Although some New Zealand district health boards have implemented the strategies, to date no studies have been undertaken as to the impact and acceptability of the strategies within a New Zealand context. This study set out to address the lack of local research by exploring the experiences of staff who successfully implemented the 6 core strategies in a New Zealand mental health unit. The unit is situated within a public hospital and provides acute psychiatric care. Over a 2-year period, the incidences of seclusion at the unit were successfully reduced by 90%, which included a 10-month period of no seclusions. Overall, the unit provided an example of successful application of seclusion reduction strategies with a lesser but positive impact on restraint use. The aim of this study was to explore the experience of clinical leaders and frontline staff in implementing seclusion and restraint reduction strategies in an acute mental health unit. It was anticipated that the study would provide an understanding of the impact and acceptability of the 6 core strategies, including perceived barriers or facilitators to their implementation. A qualitative descriptive methodology was used to guide the study. 6 key informants were purposefully recruited to participate in the study. Focus groups were used to gather the participants' experience of implementing the strategies. Separate focus groups were conducted for clinical leaders and frontline staff to facilitate the confidential sharing of negative as well as positive experiences without undermining the working relationships between the 2 groups. The focus group discussions were recorded and transcribed. Thematic analysis was used to uncover insights about the experience of implementing the 6 core strategies from the transcribed data. 3 themes were drawn from the participant experiences. The themes describe how participants' perceptions of their roles changed once the strategies were implemented and the resultant culture changes that occurred. The first theme, Rethinking Power and Control, captured the negotiation that participants had to undertake in order to manage the tension between safety and supporting service user rights and recovery. These quotes illustrate a shift towards a more collaborative rather than controlling approach. For the participants, the renegotiation and sharing of power and control was the foundation for seclusion and restraint reduction. However, this process was complex because of deeply held beliefs about the need for seclusion and restraint for ensuring safety and medical treatment. While seclusion was seen as an important but rarely needed last option, beliefs about restraint use were more ambivalent, as it was seen as necessary for enforced administration of medication. Ultimately, though, there was a perceived change in the power dynamics, and staff were less likely to perceive crisis situations as confrontations that they needed to win. Theme 2, Into the Unknown, captured the participants' experience of implementing the specific strategies. Overall, the findings suggested that this involved 2 separate but interlinked processes. Clinical leaders took a key role in introducing training and practical policy changes to reduce seclusion and restraint, which in turn allowed staff to interpret and respond to the changes in ways meaningful to them. Ultimately, these dual processes influenced staff's daily interactions with service users resulting in the development of a greater responsiveness to service user needs. While training and policy changes facilitated a reduction in seclusion and restraint, this did not necessarily equate to all staff changing their attitudes towards these practices. Staff reported refraining from using seclusion as the new procedures made using the practice uncomfortable, and they were fearful of others' reactions if they used it. Significantly, this finding suggests the strategies themselves do not create the deep culture change that Huxhorn, 2005, deemed necessary for sustained seclusion and restraint reduction. Staff also felt pressured by the public display and continual sharing of data, which is recommended in the 6 core strategy guidelines, as they did not value the creation of a competitive environment. This particular staff experience had not arisen in previous studies, and the use of a competitive environment may be more reflective of American culture, where the strategies originated, rather than the egalitarian and collective approaches common in New Zealand culture. The addition of sensory modulation tools and strategies were appreciated by staff, although they reported that people experiencing high levels of distress and/or agitation often did not want to use the sensory room. However, they supported service users by using sensory-based strategies within the broader environment and recognized the importance of the sensory aspects of interpersonal interaction. Staff strive to provide a grounding and calming environment in general through the use of different strategies and processes, for example by having regular morning karakia, playing the guitar, and singing with service users. Staff also described increased tolerance for extremes of emotions from people they work with. Staff found this helped service users manage heightened arousal states, particularly if newly arrived to the unit, angry, scared, and afraid, as it usually took some days for them to become comfortable enough to leave the intensive care unit to go to the sensory room. The participants reported drawing on consumer representative input in the implementation of the strategies. However, they did perceive there to be some issues with using formal peer support in an acute setting, although they actively supported informal peer support relationships among service users and saw this as important. Finally, participants valued debriefing as a tool for emotional and informational support for staff. They also reported using service user debriefing to support learning from each seclusion and restraint incident, but there appeared to be less emphasis on mitigating the emotional trauma of seclusion or restraint for service users. Theme 3, Getting Staff on Board, provided an account of the changes frontline staff undertook to support the seclusion and restraint reduction project. This involved negotiating resistance from other staff, and 2 of the participants took on roles as staff champions of change. They were comfortable with challenging established unit norms and role-modeled different attitudes and approaches to other staff in order to decrease seclusion use on the unit. The findings suggest that frontline staff champions were able to support the shift in staff attitudes and contribute to a deeper culture change related to reducing seclusion and restraint. The participants perceived their primary role was to develop new ways of working, which created a welcoming and safe environment, built therapeutic person-centered relationships, and offered more flexible and individualized responses to service user distress and agitation. Collaborative relationships were sustained through staff providing cultural support and clear communication with service users, family whānau, and amongst the multidisciplinary team. As Barry's quote suggests, the use of seclusion was seen as a failure of the system to some extent, and working alongside people to assist them with managing their distress became the new best practice. The findings suggested that the organizational change involved 2 separate but interlinked processes. Clinical leaders introduced practical policy changes to reduce seclusion, which in turn allowed staff to interpret and respond to the changes in ways meaningful to them. Ultimately, these dual processes influenced staff's daily interaction with service users, resulting in reduced use of both seclusion and restraint. The 6 core strategy guidelines and related literature often discuss seclusion and restraint as inseparable practices. However, differing values, beliefs, and issues regarding the use of restraint as opposed to seclusion may require different processes and strategies to be taken for reducing each distinct practice. An unanticipated discovery was that many of the frontline staff perspectives of the strategies were not reflected within the existing literature. This finding led to the consideration that management or clinical leaders' perspectives are often more reflected within the seclusion and restraint literature than those of frontline staff and service users. This study also highlights the importance of developing champions of change amongst frontline staff. As well, this has been acknowledged at a theoretical level in many studies, i.e. leaders saying it is important to engage frontline staff. This study begins to explore how this happens in practice, which is a valuable contribution to the literature. Although all participants valued debriefing as a tool for emotional and informational support after seclusion and restraint events, the focus on debriefing for service users was primarily on what could be done to prevent the incident from happening again. It appeared little recognition was given to mitigating the trauma of seclusion or restraint for consumers during debriefing. The study has several limitations. The timeframe and scope of the study needed to be contained to meet the requirements of a dissertation within a Bachelor of Health Science honours degree. This meant having a smaller participant sample and a focus on staff who had been significantly involved in the successful change process, which may have contributed to a narrow or biased range of views within this study. An intermediary attached to the unit also approached participants, and this process may have influenced who volunteered. Only data most relevant to the research question were prioritised and presented, in order to contain the scope of the project. The researcher's own worldview may have influenced the analysis of data in determining which aspects of the findings were highlighted. The findings highlight several considerations for practice and research. Organisations need to put equal emphasis on clinical leadership and frontline staff contributions in the implementation of the strategies. It would be beneficial if future studies explored the experiences and opinions of non-champion frontline staff to increase understanding of staff perspectives and experiences in reducing seclusion and restraint practices. Exploring service users' perspectives of the strategies is also vital. The findings suggest that different entrenched staff attitudes and beliefs about each practice continue to influence decision-making regarding the use of seclusion and restraint, and therefore differing strategies may be needed to reduce each practice. There is a need for further research into the impact of staff attitudes on seclusion and restraint use. Further research into the role and value of informal peer support would be beneficial, as would studies that more clearly identify barriers to formal peer support processes being implemented. The creation of an encompassing sensory environment to welcome and comfort new arrivals at the ICU was attributed by staff to decreased use of seclusion and restraint. They felt this assisted service users in self-regulating arousal states, and further research is needed into using sensory strategies within this specialized environment. The full research report, Health Professionals' Experiences of Implementing Seclusion and Restraint Reduction Strategies in an Acute Mental Health Unit, can be found on the TPO website.